Welcome everybody to this episode of Gatekeepers Journal Club. Rich did an introduction, but there are still people coming in. Joined by Dr. Brad Abicht, I'm Jeff Dykes. Our guest tonight is Dr. Rachel Albright. Thank you for joining us, Rachel.
Yeah, of course. Thanks so much for having me.
Absolutely. We're going to talk about patient expectations and hallux valgus surgery. If you are a podiatrist, you most likely do hallux valgus surgery. And in those patient rooms, you're going to have conversations where patients are asking you 100,000 different questions. And it's important that we all see eye to eye. Are their expectations matching what you are expecting them to take away from that? And sometimes that happens and sometimes that doesn't. So I think this was a fantastic way to explore that. Brad, how are you doing tonight?
Doing great, man. Super excited to talk to Rachel about this. Most of the time we're looking at x-rays and talking about procedure specific stuff, but this paper's a little different and really liked reading it. And um, yeah, I got my own thoughts on it, but we'll save that for later.
Yeah, I think it's interesting that the way that we typically approach cases is a little dehumanized. And I think we're all guilty of saying, what do you have next week? Well, I have an ankle, I have an Achilles, I have a Jones fracture. They're like, what are their names? I have an Achilles, I have an ankle, you know what I mean? Like, I can tell you what I have. I don't really know, it doesn't mean that we don't care about the patients, but there is somewhat of a disconnect there in terms of patient care. So, Brad, you want to talk about the article a little bit? Then we'll jump into the article and then we'll even go through some cases and talk about our perspective as surgeons and how we think about talking to patients and exploring their expectations.
Definitely. I usually give a little summary on the paper, but actually, before I do that, Rachel, do you mind just kind of letting people know a little bit about yourself, where you're from, or where you practice, and maybe what got you interested in this paper, or how you got involved with this?
Yeah, absolutely. So I'm currently in Stamford, Connecticut. I'm with Stanford Health Medical Group, a fairly small group in the big scheme of things. We're like 45 minutes from Manhattan, so we have a lot of competition there. And as far as my research background, I do serve as the deputy editor for JFAS, and then I'm on the board for my medical group in the state. But what got me interested in this is, basically exactly what you guys were saying. This was a long time coming for us. We initially did a paper that was on radiographs and their association with patient satisfaction, and we found that no radiographic angle correlated with patient satisfaction, and that was surprising. That is a 180 contrast from how I was trained, what I was told, measuring these angles, and it turns out the patient it doesn't seem to have a correlation with how the patient feels postoperatively, and that paper initially sparked this whole thing.
That's awesome. Yeah, I can remember like when I first got out of residency, trying to explain to my own patients, bunion surgery, and I'm going on the angles and talking about this and that. And turns out they didn't really care what I was talking about as far as angles and radiographs. And, they just like your paper notes, they want to know, is their pain going to be gone? Is that bump going to be gone? Is their function going to be improved? We're going to get into some of those details, but
I do think
yeah, that's
there's
a
a strong disconnect. I've found that when you first come out into practice, you want to give the patients all of your knowledge. You're so excited. You're like, here are all the procedures we could do. Here are all the angles. Look at your x-ray. I'm going to give you all of this information. And then you met with a blank stare and they're like, so what can we do about this? And you're like, oh, okay, there's just a huge that's where it starts to become a disconnect between, I think, as a younger person, and I was guilty of it. Like you just said, Brad, you're giving them all of your information and they don't necessarily want all of your information. They want the bullet points of here's what we can do for you, here's how we're gonna fix this, here's the plan. And I think all of that goes along with patient expectations. But I'm as guilty as anybody of just word salad dumping all my information into their lap and I think it's like when we go to lecture and we watch a presentation, I think they say people may remember like one, maybe two things from each lecture, even if the lecture's an hour long, they're going to remember one or two things. Patients are the same way. You're going to talk to them for 15, 20, 30 minutes, and they're going to leave and they're going to call the next day and be like, how long did you say I have to be off my foot again? Like, I think we could do a much better job of communicating with these patients. So, didn't mean to go off on a tangent there, but I was guilty of that young coming out of residency, and I've curtailed that way down, trying to keep it to the meat and potatoes of what people actually want to hear.
totally agree. No, those are all great points. So let's just get into this article. I'll summarize it a little bit, and Rachel, please correct me if any of this is wrong. But this is directly from the paper. So, and I also want to recognize you did have some co-authors on this paper, and part of this show is we usually bring on one or two authors. We can't bring them all on at the same time. It'd just be too many people talking. So you did have some co-authors on this paper. But this was published in JFAS, so the Journal of Foot and Ankle Surgery 2025. And this was a qualitative analysis of patient expectations. So, patients that were undergoing hallux valgus surgery, they underwent an interview, typically somewhere between 15 and 20 minutes. I think the average was like 18-minute interview. And then there was some coding that was applied to these questions and their answers. And then this was used to identify certain themes that were represented by these patients. And the main thing was looking at their goals for the surgery and kind of their expectations and their perception of what this surgery was going to do for them. And I think some of the key, goals that they mentioned in the paper here, or that you mentioned in the paper, it seemed like pain and activity limitations were some of the main concerns or the main goals that influence patients to want to pursue bunion surgery. Um, Cosmetic appearance actually came up, or so cosmetic improvement was expected postoperatively, but that was a second factor compared to the pain and activity limitations. But they did expect to have some cosmetic improvement, and they also linked that with the ability to wear certain types of shoes, which I thought was pretty interesting. So, it needs to look good, and then they want to be able to wear their shoes post-operatively. And then one other big factor that was pointed out in the paper, there was quite wide variability in patient expectations postoperatively, and you would expect that probably from a diverse group that is interviewed. Um, but I think a good point was made in the paper that we need to have comprehensive and clear postoperative instructions for our patients, and this is highly valued by our patient population. So. Those were kind of some of the summary and the key takeaways from the paper, and we can certainly get into um, some of those factors, but I don't, as far as I don't know of any other paper that really kind of looked at it this way. And maybe you could talk a little bit about that structure and the qualitative analysis, and maybe even how that differs from PROM scores, because we do have those these days, and some people are including those in their research as well. But this is a little bit different than that, right?
Absolutely. Yeah. This is a methodology that a lot of people are not that familiar with. So, in the medical community, we do things quantitatively, which is the other side of the coin. That's your t-test, your chi-square test, and you're taking those results and you're generalizing it to a larger population. And that's a quantitative study that I think all of us are used to. But qualitative is kind of the other side of the coin. Um, you are not taking these results and necessarily generalizing them to the whole population. You are really trying to evaluate a phenomenon or an emotion or an experience. And we don't believe that emotions, experiences, phenomenons can be evaluated on a quantitative statistical level. So so the goals are very different, but with this research, it was based on going straight to the horse's mouth and interviewing these patients that were already scheduled for bunion surgery. So they already knew they wanted to get it done. So they had to have had consultations with doctors, kind of talked about it, knew it was for them, and they were already on the schedule. And then I think the interview guide is in the article that we used. And we just kind of, asked them a bunch of questions, went down some pathways with them to kind of figure out what their goals were. And in a nutshell, it's a very long process to do qualitative work. You have to transcribe the whole interview, so that takes hours. And then you come up with these codes in order to come up with sort of ideas, like chunks of ideas. And then the codes are the building blocks for your theme. And then the themes are the results, basically, of the paper. So it does kind of coincide a little bit with a quantitative method, if your mind kind of thinks that way. I mean, there's definitely similarities, but it's certainly a different protocol. And the way you minimize bias and the trustworthiness of the article is in a different manner than the way you would do it quantitatively. If that's like really in the weeds. Maybe that's more in the weeds than you wanted to get.
No, absolutely.
Yeah,
Go
it
ahead,
is,
Jeff.
but it's very interesting because I think, like you said, we're all used to doing quantitative things, like what are their pre-op AOF scores, post-op scores? What are their radiographic angles pre and post-op? Like things that we could tangibly measure, and the inter-rater reliability of those is very high because you could look and you can see, yep, there it is, there it is, there it is. And this has so much more feeling, and every patient is going to be a little bit different. I think that it makes sense that they would come out with very similar themes just because common sense says, well, why are you going to the doctor? My foot hurts. Well, you're going to expect them to expect pain relief, right? That's pretty common sense. But I don't know. I think it's such a different way to approach a paper that we're not, at least my brain is not used to trying to understand how do you put all of this information together and formulate it and spit something out that is useful knowledge, and you guys did that, and this is a helpful paper, I think.
Thanks. I'm glad you feel that way. But to go
Were
back to
you
your Oh, go ahead.
Oh, I was just gonna say, were you surprised by any of these findings? I mean, to me, the findings kind of make sense, but I don't think it's ever been shown this way before. So, like, I don't know if you were surprised by any of the findings, or maybe it changed. I don't know how you practice or what you actually do to educate your patients.
I was surprised that the postoperative protocol was so variable. And, I guess it would I guess it sort of makes sense, but the reason why I became surprised is because I had to read a lot of literature, background on this. And there are papers that have said that a patient's quality of life is lower if the postoperative recovery time is longer than expected. And with that in mind, I was like, "Oh, geez, maybe we're not doing a great job of really ironing this out." I've certainly had personal experiences where a patient was, like, wondering why they couldn't run after, like, 3 weeks. Um, so, yeah, I would say the postoperative recovery time being as variable as it was a little interesting to me. I also thought it was interesting that patients correlated, um, the shoes that they wanted to wear with cosmesis. I feel like those are 2 separate things in my opinion, but the patients very much would talk about their shoes in the same sentence as the physical appearance of their foot, and they also were concerned about things cosmetically that I wouldn't be concerned about as a surgeon. For example, how long they would have edema. I mean, I don't really necessarily talk to patients about edema, but now I do.
Yeah.
And their scar. I mean, I know that these things exist, but just from a deformity correction standpoint, not really thinking a ton about the scar or the edema. So just like little nuances like that, I thought was pretty interesting.
So
I
in,
want to
in your paper, sorry, Jeff, you point or it's noted that I think 19 of the 20 patients were female. Do you think if there were more males in the study, you'd have a little bit different results or goals, or some of that stuff might look a little different? They wouldn't be necessarily worried about getting back into their shoes or the cosmesis, or I don't know, maybe they'd have different goals.
I absolutely think they would have different goals. I mean, men and women aren't the same, right? um, but I also, the bunion population tends to be majority women. But I don't know if I necessarily believe that women just deal with this medical condition more than men do. I think that women just don't like the physical appearance of it, and then that's the first step, and they care a little bit more about cosmesis than men. Now, I don't have data to support that, but I just can't imagine that hallux valgus is affecting women at a different rate that it's affecting men. I just feel like maybe women are complaining about it more. So, yeah, I think it would be different if we had more men. They're just not as common.
I want to get you guys' perspective on specifically patient expectations, but how you approach when you talk to these patients who are going to have whatever surgery. We'll use bunion surgery as a consistent theme throughout the night, but any surgery really. I find myself overestimating length of recovery because what I always think in my mind is if I tell them it's going to be 2 months and it's 2 months in a day, they're angry. And if I tell them it's going to be 6 months and it's 2 months in a day, they think they are the fastest healer and you are the best doctor. And went fantastic. And look how great this went. He said it was going to take forever, but look how fast I'm healing. And it's a weird balance though, because sometimes you push people away if you're like, this is going to take 6 months. And then people are like, oh, well, never mind. I don't want surgery. But in your mind, you know that, oh, well, it's going to be way faster than that. So you don't want to lie per se, but I do think setting realistic expectations, but I kind of do it a little bit longer so that they seem a little happier. How do you guys approach that?
I agree with you. I do skew it a little bit longer. I think that is a challenge when you are very early in practice, right? When you've only done maybe a couple on your own, it is hard to tell a patient exactly how long they'll recover. So that is something about being a little bit more experienced, right? Now we kind of have an idea, okay, this is how long people typically recover when I do this case. So that helps obviously now, which I didn't have when I first started. But I agree, I do tend to skew it a little bit longer for that reason, and I've had the same problem where I've told someone, "Oh, yeah, it's gonna be 6 months," and they're like, "Oh, we'll forget it," and I'm like, "Oh, maybe less. Don't leave."
But maybe you're a good healer. I don't know. Come on, come back in. I bet we can get you in 5. You're a 5-month type of person.
Right. Yeah.
Brad, what
I
do you
do
think?
love that when a patient tells you, or you tell them, yeah, it's going to take 3 months, 4 months before you're, healed. And they said, oh, well, I'm a really good healer. And then in your head, you're like, okay, you're going to probably take like 6 to 8 months. Then,
Yeah.
but no, I agree with you guys. I think what is the saying? You under promise and you over deliver. So you got to set those expectations and they have to be realistic, but I'm not going to be on the short end of those realistic expectations. So, and then you come out looking better when they heal a little faster. But yeah, I think you have to be realistic with them. I've tried to employ a lot of picture examples. So pictures of x-rays, but also pictures of feet and, different examples, like someone that maybe had a little more swelling, someone a little less, just kind of give people an idea of what to expect after surgery. And so I focus more on that now, more so than like, I'm going to show them the angles of on their x-rays and I'm going to show them how I'm going to correct everything. And like, they I feel like it kinda glazes over them, whereas they see a picture of a foot, they can relate to that and hope that their foot is gonna look like that in the future too.
For anyone who didn't read the article, I want to go through some of the main bullet points of the things that
Yeah.
were talked about in the article, and then we can pick a few to kind of hammer down on. So, pain relief, return to activity, fear of progression. I thought that was an interesting
Mm,
one. We're going to come back to that one. Clear postoperative instructions, realistic recovery timeline, shoe wearing ability, cosmetic appearance, reliable information access, acknowledgement of their fears, and radiographic outcomes. Let's go back to fear of progression. I think that's an interesting one because I get these people all the time who come in and they're like, "Well, I wanted to get this fixed before it got worse." And I'm asking them, "Well, does it hurt you?" Like, "No." I'm like, "Well, then we don't need to be having this conversation at all. I'm not fixing, what if you get infected? What if you're the type of person who gets infected and has a mess and then all of a sudden you're like, I didn't even need surgery. My foot didn't even hurt. Now that just lives in the back of my mind of like, you better need surgery and beg me for surgery if we're going to go down this path together. What are you guys' thoughts on doing surgery in the setting? I'm not saying people are doing that only because people are fearing that it's getting worse. But Rachel, what are your thoughts on that aspect of this? I didn't really put that together with the rest of these, but I thought that one was an interesting bullet point.
Yeah, no, I agree. That was an interesting thing that we noted in the interviews. And I too have patients coming in and they want to get it done for fear of progression. Or they say, I don't want to be too old to get it done later. I hear a lot about that. And I will say that I agree. I don't do it for fear of progression. And one of the reasons, I mean, I hate to say it, but it is litigation, reasons. AAOS does have on their website that they do not recommend this be done for fear of progression. and it's, like, right in black and white on their website, and it's aimed at patients. I think it kinda comes down to which surgical society is closely aligned with your values, you know? I don't think ACFAS necessarily has anything right on their website about that, but, I mean, if you closely align with a society and then they have somewhere in black and white that they don't think you should be doing it and then you do it, I think that's I don't know, it's a little risky.
Yeah, Brad, what do you think about that?
Um, I would definitely not do it as the sole driver of bunion surgery. So, you have patients that have a symptomatic bunion. Let's say they have pain or some kind of dysfunction, but then they also have fear of progression. So I think when the fear of progression is associated with other factors, then it's okay. But if it's the sole thing they're coming in for and it's otherwise asymptomatic, then yeah, I kind of just counsel them on, hey, this could get worse, but right now it's okay to monitor it. Let's try some of these conservative things, and if we need to fix it down the road, we can. Another thing I hear from patients, with that fear that it's going to get worse, they have an aunt or they have a grandma or somebody in their family that they've seen their feet, and they are so worried about turning into that person later in life, and so they have this fear of it getting worse based on one of their family members. So I hear that all the time from these patients.
Yeah, that makes it tough. What do you guys think about another interesting bullet point I thought was reliable patient information? They're coming to the doctor not only because you can fix their surgery, but to get all the information from you. I have been in medicine long enough, and I am not talking only about podiatrists. I've been around general surgeons and ortho and you name it. ER is pretty good because they deal with a lot of people with quick information, but some of us are horrible communicators. Some of us are just absolutely terrible. You might be fantastic with a knife in the OR, but your bedside manner is either terrible or not polished enough. And a lot of patients are leaving. I want to say a lot. Some patients are probably leaving some doctor's offices thinking, I didn't learn anything there. I'm going to go to Google and YouTube and watch the video, and they're going to absorb this kind of generalized information that maybe someone's talking more at their level. Maybe someone's a bad communicator because they said hallux valgus instead of bunion. But in our mind, I find myself doing that all the time where I'm using these technical terms without realizing that I'm using these technical terms. What do you guys think about how we can better, like, it's one thing to find all these problems and then be like, what are you going to do? How do you think that we can better communicate with patients either on their level or keeping them from having to go to Google as soon as they run out of the office?
What do you think, Rachel?
Well, it's funny you ask that because I agree it's a problem. And I don't think that we're that great at it, and I think that there's a lot of room for improvement. So, we are currently, as we speak, trying to come up with a survey that patients can take in the preoperative setting. So, it's for the pre-op visit, and it would be a survey that would quickly identify what their goals are, and they would take it before they see the doctor so that you can look at that survey and look at how they answered things, and then you immediately can pinpoint, I need to talk to them about this because this is not going to happen. Or I need to talk to them about that because that's an unreasonable expectation. And it's supposed to help guide the conversation. Because, the issue I think is sometimes we're signing people up for surgery and we don't have a huge background on them. I have patients coming in for surgical consultations. I meet them, one time for 15 minutes. It's really hard to get down to their goals. And
So will you do surgery on someone that you just met? Because I'm always on the fence about this. Like, you can get a vibe from certain people right away. If they break something, they got bones sticking out. Okay, put that over there. We gotta fix these people. But certain p and you all of us have been burned, like, "Oh, I thought she was nice and normal, but she was crazy." I don't know why I said she, no offense to the females. I could say he too. He was crazy, you know what I mean? Like, I've been burned before.
It's Dave.
Yeah, thank you. My wife's probably actually, she's not listening, she doesn't care what I do. Um, so I've been burned before by some of these patients, and in that little short window, you're kinda like, do we need to get to know each other first before we go down this path together? Will you operate on someone that you just met elective surgery?
Yes, I will. However, only slam dunk stuff. And I think that the slam dunk stuff is personal for every surgeon. It's the stuff that you just it's like a science to you. You got it down. Of course, that person could still have a complication, but that like slam dunk stuff, I feel comfortable doing it without knowing them. I do not do, uh, cavus or flat foot reconstructions on somebody I just met because the recovery is just a little bit longer.
Mhm.
Um, some forefoot stuff, some like an MTP joint fusion is kind of a slam dunk. That's what I consider a slam dunk for me. So I'll do that if I just met the person. But
Brad,
yeah,
what do you think, Brad? And then I want to come back to Rachel's point because I inadvertently cut her off when she's talking about this patient survey, which I think is a fantastic idea. But Brad, do you operate on people that you just met electively?
Kind of like Rachel, yes, but it depends on the pathology and the procedure. And I think, we've talked a lot about MIS on this podcast. MIS is one thing that has allowed me to probably do that more and not worry as much, just because let's say for some of these bunions, the recovery is so much more simple and I think less risky for a lot of these patients. So I'm comfortable meeting them once they have a bunion, we talk through it, and then we sign them up for surgery. Whereas maybe in the past, if I was going to do an open modified lapidus or an open scarf or whatever it may be, I might want to get to know them. We got to talk a little more, get them prepared. So I think MIS has done that for me. But there's certain things like hindfoot fusions, flat foot, cavus, TTC fusions. I mean, those are things where we got to date a little bit before we sign up for that procedure for sure.
Yeah, Rachel, keep talking about that preoperative survey because I think if there was some sort of standardized, are you talking about that you're trying to create for your own clinic, or you're trying to create as part of like ACFAS and making it kind of a national, like here, use this before surgery?
yeah, we're trying to create it for everybody and disseminate it to members. ACFAS is um, funding it. So it's part of the ACFAS grant. And yeah, we're trying to disseminate it to everybody.
I think that's fantastic.
This might be a good opportunity, just to bring this up. Your paper was funded by a grant from ACFAS as well as NIH. Can you just talk a little bit quickly about how that works, or maybe why someone might want to consider pursuing a grant for their research?
Oh, excellent. Yes, lovely. Um, I almost feel like this is you're letting me do a shameless plug here because
I
I
am,
yes. So
but
I'm
I'm also interested.
yeah. So the research committee for ACFAS runs the grant program. And I'm no longer on the research committee. I'm the past chair, but it's a great program. So it's $25,000 for a new investigator and 75,000 for an established investigator. And the reason why funding can be helpful is because if you're doing prospective research, which is, for those in the audience who aren't sure what that means, it's you are actively gathering data. The data is not in existence. You have to gather it. That's prospective. A lot of times you have to incentivize patients. So we were giving patients like $100 gift cards to do these interviews to get 20 minutes of their time and then to be able to go back to them and do cognitive interviewing later so that we could validate everything. And it is really hard to recruit people. That is the hardest thing about prospective research. It's definitely higher level evidence. It's wonderful when you can do it, but the recruitment is hard. And if you have some money where you can pay them, you have a higher likelihood of being able to recruit the people you need. So grant funding can be really essential for that. You can also use some of the grant money to offset your salary because I mean, it's time out of your day that you're not seeing patients when you're doing this. You can use the grant money to pay a statistician. You can use it to pay for software, statistical software. So there's a lot of things that the grant money can be helpful for where, a novice researcher is not necessarily going to have easy access to these things. But
Yeah, and how do people apply for that if they want to? Is it just through the ACFAS website or what?
yeah, yeah, it is. So we do require a letter of intent. Very simple. The letter of intent is simply this is the title, these are my proposed authors, this is kind of what we want to look at. It's just like a short paragraph is fine. And the reason why we want that is because we do gather experts in the topic areas to review the grants. So that's mostly just for the review process. And then you submit the grant. The grants are usually due in around October. And then the letter of intent, I want to say, is maybe due a month before that, maybe September, August. The grant does follow an NIH format. This is all on the ACFAS website. So they give you samples of what the grant looks like. You do have to have letters from other people on your research team, like letters of support. So it's not recommended to submit a grant if you just have an idea up here and you don't have anything else like put into place. I mean, you're going to want a letter from your statistician. You want to have that already figured out. If you have a research coordinator, if you need your department to support it because you're going to use their facilities or whatever, you got to have those letters in place. So it is a fairly rigorous grant process. It's not simple. It's not something you can do in an evening, but it is all on the website and we do give you feedback. So if you don't get a grant, you'll get feedback on how to make it better.
Sounds good.
We have a question that came in from upcoming podcast Pod Patrol guest Mark Allen. Does waiting on progression to a more severe deformity, OA, and pain potentially compromise the outcomes when surgery is finally undertaking? So, Rachel, what are your thoughts on that? So, if someone comes in and they want to avoid the progression. At this point, it's maybe it's an easier surgery for you because it's not as an aggressive of a deformity. I think what Mark is alluding to there is if the deformity progresses, do we still have the same outcomes? Maybe your procedure choice changes. What are your thoughts on his question that says, what are there any downsides of waiting or kicking the can down the road?
Yeah, I mean, of course, there's this idea that maybe it's getting a lot more severe and now your choices are limited now, but it's not guaranteed to progress. So, this idea of progression is kind of like hit or miss. It might not get worse. If it does get worse and you're looking more to an arthrodesis, whether that be a first TMT or an MTP, I think the outcomes are better. Personally, with fusion, I think one of the biggest issues is recurrence of the deformity, especially if it's kind of a mild one or a moderate one. And, the longevity of bunion surgery is what, about 30 years is what we have in the literature. So if you do it on someone who's like 30 or 40, that's probably not going to last their lifetime unless we get longer data. So if you were to wait till it was a little worse and then you did an arthrodesis, that could be the most definitive surgery they would need.
Well, for me, if they come in early, they're going to get a lapidus. And if they come in later, they're going to get a lapidus. And if they wait even longer, they're going to get a lapidus. So, Brad, what are your thoughts?
I would never do that, Jeff. But so actually, while Rachel was saying that, it made me think it'd be very interesting to do this type of study for an arthrodesis procedure because I feel like I get a lot of patients that come in and they have a preconception of what a fusion is going to do to them. And, when you mention the word fusion to somebody, no matter what joint it is, they all of a sudden think that they can never walk again or that their foot will never move or bend, and we all know that that's just not the case, right? And I kind of agree with Rachel. I think in many cases fusions are actually more predictable. They have great outcomes. um so I'm not afraid to fuse a big toe joint if I have to, if there's some concern for arthritis or whatever it may be. But the patient's perception on a fusion, um I would like to see a paper like that because I bet there'd be a lot of anxiety uh, about the expectation of what their foot is going to be after a fusion. And I don't know that that's really ever been looked at or done in this way, at least. Do you know, Rachel, if that's been done or
I don't think it has been done, and I agree with you. That would be interesting to get from the patient's mouth. What exactly are your fears here? What do you think is going to happen to your foot? What do you
no?
think you'll be able to participate in postoperatively? Because that does seem like a disconnect between what we know and then how they're perceiving this procedure.
I have a question for you guys. Do you guys give your patients a handout when they leave that says, here's the name of your procedure, here's the expected time frame to
Yeah.
recovery. Like, if we have the data here that says, here are all the things that the patients are wondering about, like you said, Rachel, giving them a survey, I think that's reasonable too. But even before we get to that point, I don't have a handout for like, here's your bunion one, here's your ankle fracture one, here's your Achilles one. Like, in my mind, if they ask me, okay, here's the information, and then they leave and they're like, I don't remember what he said. And how could you? We talked about 50 different things. Do you guys give handouts per surgery? Like, here's your expectations of a bunion. Do you do that? I don't.
I don't, but it sounds like a great idea, although I would be a little bit afraid that maybe I would be, married to the timeline that I give them.
Yeah, true. Brad?
I I give them a surgery folder, and in that surgery folder has a lot of information. But part of it is I do write down like their procedures. I actually give them some websites, credible websites that they can go to. And one whole reason that I actually got into research in the past was so that I could give my patients the papers that I published, or at least if they're interested, they could go look it up.
Ooh, look at you. Look at me. Here, read this. This is by me.
No, so in part, there are some publications that have videos attached to them, so that also allows them to go and watch the video on their exact procedure that they're going to have. And I've had you went, so many people come back and tell me they've watched the video, and then they went on YouTube and started looking up other videos, and I tell them not to do that. But so I think it just gives them an opportunity. Not everybody's going to go out and do that or read the paper or watch the video, but if they want to, at least they have a credible source and they're not just like Googling it and finding something random. So I do give them that.
What do you think about jumping into some cases here, and then we can give our perspective for people listening, watching, whatever it may be, in terms of analyzing these x-rays and deciding what we might do and what we might tell certain
Yeah,
patients. You want to pull those up, Brad?
for sure. This is kind of what we do, Rachel. So we're going to pick your brain a little bit on some of these cases, and I'm going to share my screen and we'll try and talk through some of these things. This will be a little different because we're usually focused on like the x-rays and the procedure, but we're going to try and focus on what the patient might be expecting with this stuff. Were you going to say something, Jeff?
I was gonna talk while you were pulling that up, but it's up, so here we go.
All right. Well, so that's the paper, and I had your figures from your paper, and maybe we can just buzz through these two as well. This was your figure one from the paper, and this was an interesting figure to me. It took me a little while to sit down and actually kind of connect this, but then basically, there was some crossover between patients mentioning that elimination of their pain, improvement of their activity and function after surgery, those were two of the biggest things they mentioned and oftentimes went hand in hand. And then there were some other things like cosmetic appearance that also overlapped. And then these other things that you see. Um, is that kind of how I would summarize this chart or this figure, Rachel?
Yeah, absolutely. Showing overlapping of ideas. Mhm.
Yeah, it's kind of a cool way to show it in that figure. Figure two was just the questions that went along with your interview and what the patients were actually answering. And then if their answer was a little vague, you had a follow up question or a probe to try and get them to expand on that answer a little bit. So those were just the questions. And then the patient demographics that you included in your table one. And we won't really go over that too much, but so we'll just go into these cases. So I have a couple examples here on the left. This is a 50-year-old female, has had a previous right open bunionectomy. Unfortunately, had developed an infection, underwent hardware removal, and she's got some medical problems. But I include the infection and hardware removal because she's coming in now and she has probably some preconceived ideas of bunion surgery and hasn't had the greatest experience on her other side. Just looking at, I guess, her foot and these X-rays. What procedure are you guys probably going to do for this?
So, I think we'll get to the procedure selection choice in a minute because That's part of what this is, but I think let's back up a little bit and talk about patient expectations. When someone has vitamin D deficiency and a smoker, I think they have set themselves up for failure potentially. And if we don't address those underlying comorbidities that we know are risk factors for failure, then we're not doing our job appropriately. And our expectations for the patient, if I see, oh, they have everyday smoker and they have vitamin D deficiency, in my mind, I'm like, well, that's less likely to heal. But does the patient understand that they're less likely to heal because of those things? That's just one thing that I took away from from the patient on the left is those things are fixable. Some things are not. We can get diabetes. We can get your hemoglobin A1C down. We can get your off cigarettes. You know, I tell people if you're going to pick a time to stop smoking, now's the best time you can do it. It's gonna. I don't necessarily make everyone stop smoking. I think that may be sometimes unrealistic. Sometimes people do stop smoking, and that's fantastic for their overall health. But what do you guys think about doing the surgery in the first place if we know in our mind as clinicians and surgeons that those risk factors exist and they are potentially at higher risk for complication automatically but off the jump I think our expectations are different than the patients. What do you think, Rachel?
Yeah, no, I was absolutely going to say that I do not do surgery on smokers. I just don't do it. I say
I
you
mean, I
guys.
think the data shows that it's just they're more likely to have a bad outcome, and then if when you do have the bad outcome you're like, oh yeah, I guess we knew that you were going to have a bad outcome. You're like, we shouldn't be surprised in that situation. Is like
Yeah.
the data
I
shows all of that stuff.
Yeah, the only exception I have to that is if it's trauma,
Sure.
or, if they're diabetic and or something like that, and they're gonna lose their limb or something, but an elective surgery, yeah, I don't do it on smokers.
What are your thoughts on that in terms of patient expectations, smoking and vitamin D, Brad?
Yes, I guess I'm a little different for at least smokers. You know, these are things we definitely counsel our patients on. We try and get them to stop smoking. Um, I can't say I am really successful at getting patients to stop smoking in order to address their bunion. So likely that patient's just probably never going to get surgery if you're following that rule. Um, Certainly, I can check their vitamin D and then get them boosted back up and in a normal range. So I do that. But I will operate on smokers, and that's again one reason I'm so into MIS is that I think it does mitigate some of these risk factors, not all of them, obviously, and there still can be complications. But I do just at least educate these patients on those potential complications that they can be higher with smoking, and I document it. And then if they still want to proceed with the procedure, I'm willing to do it.
So to answer your question on the procedure on the left, I would send them to La Crosse, Wisconsin and let Brad do an MIS bunion on that because if they're a smoker, they have vitamin D deficiency. I have two strikes against me. We already know that a lapidus has a mildly increased risk of non-union compared to mid-shaft osteotomies. The healing of a mid-shaft osteotomy is higher. Bone to bone is higher than trying to resect cartilage and trying to get bone to bone in that scenario. Someone that's already had infection from an open procedure, I think if you are going to do surgery on this person and I see Brad's initials on the foot, and unless you did that in the office because you're weird and twisted, then you did do surgery on this person. And oh,
All right, Jeff. So this is what we did. So both these patients, the one on the left and the one on the right, got three screws, and in this procedure, we did an MIS lapidus,
so
and there you can see.
why did you choose Lapidus? Because that I think for the amount of deformity and the um well, we don't need to get into atavistic cuneiform, all that stuff. A Lapidus, I think, is the correct procedure choice for this, but why that instead of a I've seen some of your 100% shift MIS head procedures that could have taken care of that procedure.
Yeah, I didn't feel like, when I measured this preoperatively, if you measure the width of that metatarsal at the site of the osteotomy and you move it over 100%, that's not going to get the deformity corrected. And so you'd have to move it 150, maybe 200% to get that corrected. And that's just not realistic, especially in a smoker vitamin D patient. And so, in this particular case, I do an MIS lapidus in about 3% of my bunions, and she was one of those people. But you can see her small poke hole incisions, and again, hopefully we're mitigating her risks by doing this through an MIS approach, and she doesn't get infected or she's able to heal. And she did go on to heal pretty well, actually. There she is at 9 weeks, and she did unite at her tarsometatarsal joint. Um, but the point here that I was actually trying to bring up was there's a big difference in recovery between my lapidus and my distal osteotomy. And even though they're both done through an MIS approach, the lapidus still takes longer to heal from, even through an MIS approach. So that is one expectation that I try and set with my patients.
What are your
Any
thoughts on that, Rachel? Would you have
comments
done a
on that at all?
Lapidus? Rachel, would you have done a Lapidus or head procedure or said, "Nope, you smoke and you're vitamin D deficient, and we're not gonna come to an agreement here"?
Well, in real life, I would say, "No, you smoke, we're not gonna come to an agreement." But for the sake of the conversation, the angle I felt was fairly severe, and so my first instinct was definitely Lapidus. My concern with the Lapidus was, how much am I gonna shorten this because her second looked kinda long, so I don't know if she's gonna get, like, a transfer metatarsалgia, but that would be the only other thing I would think about.
How often do you see that, Brad? Because I don't see it very often. Even when we shorten the first ray, I just don't see it that often. What do you actually see that? It's like a theoretical thing, but do you actually see sub-second met pain of after these MIS Lapiduses?
I think it is out there. It's not super common. I don't see it a ton, I would say. I didn't see it in this particular case, and maybe she will down the road, develop some second ray pathology. But, if you look at where she was pre-op. She's a little shorter than the second already. And yeah, this is one thing I struggle with the Lapidus procedure is I'm going to end up shortening her a little bit more if I do a Lapidus. So, that is certainly something to talk to patients about as well. Clinically, I think her foot looks great, but radiographically, when we look at that, it's like, oh yeah, it's a little shorter than it was. So hopefully, that doesn't overload the second ray. Um, but, I've done that at my distal osteotomies as well. You can get a little shortening there as well. So, um, but I would not do, I don't know if you would, but I would not do a prophylactic DMMO or metatarsal osteotomy if they weren't having pain on the second or third mets. Some people ask about that, but I would not prophylactically cut the second or third met to try and account for that shortening.
No, I don't solve problems that aren't there. Can't fix what's not broken. If it becomes broken, we'll fix it, but you can't preemptively fix a leak in your pipe if the pipe's not leaking. Like you can't. I don't know. I don't like that because what if then all of a sudden they're like, well, now my second toe hurts, or they get a flail toe or something. Like you get a complication. You're like, well, why'd you do that in the first place? You didn't really need to. What about that second? Is that a different case there on the right? Yeah.
Yeah, so the one on the right, 75-year-old lady, otherwise pretty healthy, non-smoker, non-diabetic, just basically has bump pain, kind of a garden variety, moderate bunion, I would say, maybe a tiny bit of spurring on the dorsal side of the head on the lateral view. This patient essentially wants her bump pain gone, wants her toes straightened, and she wants an easy post-operative recovery. And those are kind of her goals at 75. So I don't know if you guys are doing a different procedure here than what I just showed you, or what are your thoughts?
Did you say that she has any medical? My headphones are dying, and I was trying to plan. I got a little alert in my headphones that they're dying. So if I have to leave for a second, just keep going. And I was focusing on what I was going to do about my headphones. So did you say that she has any health issues, comorbidities?
No, no, other than being 75, she's otherwise pretty healthy.
So I mean, I think the most important thing here are what are her expectations? If we're going to skew it in the light of why we're talking about this in the first place, because yes, we're talking about bunions, but we're mainly talking about patient expectations. Sorry, again, the headphones thing. Is she very active? What were her goals? What was she trying to get out of this?
Yeah, I mean, her main goal is get rid of her bump pain, or the pain associated with her bunion, and to straighten her big toe, and then to have a relatively easy postoperative recovery. So if I had to make her non-weight bearing, she'd probably struggle with that. Versus if I can do a procedure where she can walk on it right away and get back to a shoe pretty quickly, she's going to be pretty happy with that.
Yeah, no pain with range of motion of the MPJ, like, arthritic changes. Obviously, has the dorsal spur into the first dorsal metatarsal there, but
No joint pain, no crepitus, no, yeah, no pain on range of motion.
yeah. I mean, I think you're gonna do an MIS head procedure. You're gonna kill me. I know people are gonna kill me. I will still go
Still
in
do a
and
Lapidus here?
no, I will
Oh,
shave the top of the bone and the side of the bone and stitch it back up and let them walk on it like nothing ever happened. I will do a silver and I will shave the bone, let them walk on it the same day and do no fixation, no osteotomies, no healing, nothing. You want the bump gone? Boom, the bump's gone. 10 minutes later, the bump's gone. People kill me for that, but people freaking love it. They're like, my bump's gone. Great. Now what? Like, go do whatever you want. Rachel, what are your thoughts?
I don't think that's wrong. I mean, I think it's based on what the patient wants and what their goals are. So if their goal is just only the bump pain but they don't care about a straighter toe, then I think that's completely acceptable. I would probably do a scarf here. That's kind of one of my go-tos for mild to moderate, bunions. I feel pretty comfortable correcting a pretty decent IM, which I don't think hers is outrageous. But I would educate her that if she's having bump pain, I would educate her that she most likely is not gonna be able to get into, like, a high heel. Not because she can't, but I feel like women are wearing shoes that don't fit them, okay? I'll just be the first to admit it. I'm a woman. I can harp on my own gender. We wear shoes that do not fit us. And just because that bump is gone doesn't mean you're gonna get into a shoe that does not fit you. So I do educate people on that. You're still gonna have to wear a shoe that's reasonable.
Mhm.
yeah,
Brad,
so
what are your
Jeff
thoughts? You wanna
probably
kill me?
knows.
Wait, I
Jeff
want I
probably
want you
knows.
to kill me for doing silvers. I want you to
Well, yeah, I'm not a huge fan of that, but like Rachel said, I think you might not be wrong there. And we oftentimes look at X-rays and we're like, oh, that doesn't look good. And then you go in and talk to the patient, and they're like, "This is the best surgery I've ever had. I love it." And like, they're all about it. So I feel like in some of these situations, maybe it would work to just do a silver and call it a day.
It
Um,
does because I do it. Now, it's mostly on elderly people and they wanna walk right away. I'm not looking at a 32-year-old with a increased first metatarsal angle and being like, "Oh, we could just shave the bump down." That's not what I'm saying. I'm talking about elderly, they wanna walk right away. Maybe they're a fall risk if I start putting them in a boot or some offloading them for X number of weeks and, shutting them down, and they just want or people who are like, "I cannot take any time off of work. My foot hurts, it's killing me. I have a factory job. I stand for 12-hour shifts. I work on weekends," and I'm like, "Well, I don't know what to tell you. You want the real surgeon that's gonna fix it, you gotta be off work for a long period of time. We can do this other one." Like, I try to teach the students all the time who rotate through with me, the book answer does not always match the real life. In real life, the patient has rent to pay, they have bills, they have whatever, and they're like, "I can't take time off of work. What are my options?" You're like, "Well, they didn't really go through that." That wasn't in the book. That the book is like cut, shift, move, fuse, whatever, angles, PASA, DASA, all this garbage. And it's like the real patient sitting in front of you has a story and has something that they say back to you. So sometimes you got to factor that in. But this looks great. I'm sure she was happy with this, Brad.
She was, and I think at this point, this is my silver. So, like, me doing this is like a no-brainer and easy, and I don't worry about it at all. These patients can walk on their foot immediately, and I forget about it in 2 seconds. So, like, for me, yeah, this is a silver, and I know that this bunion isn't coming back, right? And there she is at 3 months clinically. There she is at a year, 11 months post-operatively radiographically. Um, so yeah, she was happy with that. But here's somebody that wasn't happy. So you look at this X-ray, and there's a pre-op on the left, and then in the middle, here's this patient at 2.5 years, developed extremely nice bone callus and healing of their osteotomy. But they are one of my most miserable patients. They are still having pain, and it seems to be coming from their joint. Um, they acknowledge that the bump is gone and the toe is straighter, but they tell me, I wish I never had this surgery. This is just, it's worse than it was before surgery. And this is one of those situations where you look at an X-ray and like, holy crap, that looks beautiful. Like, look at this great job I did. But then you go in and talk to the patient and they're miserable. And so this is like the opposite of the ones I just showed you. And so, again, I think it goes back to patient expectations and also maybe I missed the boat on this particular case because I was so focused on her bunion. I didn't think she had joint pain. Even though we fixed her bunion, it made her joint pain actually worse. So this was a situation where I think I missed some osteoarthritis of the joint and got it realigned. But recently at 2.5 years out, here's a CT on her, and you can see the first MPJ is fairly arthritic, especially the sesamoids. And I think that's where her pain is now coming from, is the sesamoid complex in the joint, even though we did a good job correcting her bunion. So this is a situation where I wish I would have maybe fused her instead of correcting the bunion. Any thoughts on that?
Well, hindsight's always 2020. It's one of the things that I harp on, and it's why I get into arguments with dumb people when they tell me like, "Oh, they should have thrown on 4th down instead of run it." Like, well, yeah, because the only reason you're saying that is because they didn't get the first down. I'm using sports analogies, but it's very easy to go backwards and be like, "See why that didn't work? I would have done this." And you're like, "Ugh, I hate that stupid argument." So, yes, maybe, but I try to spend a lot of extra time with patients trying to elucidate, is your pain from the bump? Is your pain from the joint? And that could be
Mhm.
hard to do because they just kind of point, it hurts here. And you're like, okay, is that the joint? Is it what are your thoughts on like a diagnostic injection into the joint? I don't know if that would help us. I'm just kind of thinking on the fly of trying to figure out, a lot of them are pretty straightforward. Like, nope, that's a bunion joint. Looks fine. Or, oh, your joint looks terrible. What are we got to fuse something there. But I don't know. What are your guys' thoughts on? I don't think you can ever go back and be like, well, I would have done that. Like, that's not fair. Rachel, what do you
Yeah,
think?
Yeah, I don't use diagnostic injections a ton for bunions, but I do
I don't
agree.
either. But in this case, it's like, could you have figured out that, oh, it is the joint and not the bump? I don't know.
Yeah, I mean, honestly, sometimes these things just don't go the way we want, and it doesn't necessarily mean you did anything wrong, or that you missed something even. But I agree with you, Jeff. I really, really do try to specifically palpate the joint versus the bump. That does seem to help decipher between the two. I also try to see, how much range of motion do they have? Is it limited? If it's limited, I'm already like, you might have something there that is just not that visible on the X-ray. And sometimes with some of these procedures, you get slight, I hate to use the word elevatus, but you get slight elevation of the head. It doesn't want to like totally sit. And then that can cause this feeling of joint jamming that is worse, post op than it was pre.
Yeah.
Mhm.
I noticed that on the X-ray. There was a little bit of elevation of the first metatarsal capital fragment. I think the alignment of the joint looked good. And on the CT, it didn't look that bad. But when you looked on the lateral view, there was a little bit of elevation. And again, Monday morning quarterback, I absolutely flippin' hate because it's so easy to look back and criticize versus the person that's actually, playing on the field and you're sitting in the stands eating popcorn and criticizing the play calls. I don't know, Brad. Like, she wasn't happy. So obviously we didn't meet patient expectations. But in this situation, I don't know that there's anything you could have done differently verbally, talking to them. Here's what could happen. Unless you maybe say, hey, I use a analogy of a tire or a wheel on your car. If it's out of alignment, it's gonna wear down unevenly. Same thing with a joint. I tell people, I had this conversation today. When your joint tilts, it starts to wear unevenly. And we know by nature of your bone tilting that the cartilage is wearing unevenly. And even if I put it back together, sometimes there's damage that's been done to the cartilage, then your joint will still hurt. I tell pretty much all my bunion patients that. I give that same analogy. It's out of position, it's rubbing unevenly. We put it back, and you still may have some pain in there. And I think that's all about setting patient expectations. At the end of the day, sometimes people have realistic expectations, sometimes they have unrealistic expectations. And the best that we can do is just give them all the information and make sure that we're clear. And I try to go out of my way and say, here are the bad things that can happen from this. So they never can come back and be like, you never said that this can. Yes, I did, Ron. Look at that right there. It says it in my note. We talked about it. And that kind of goes back to the, if I hand them this handout with information that says all these bad things on there, at least the patient expectations and our expectations start to align a little bit better.
Yeah, those are great points. And since we're coming towards the end here, I just want to leave people with this. This is directly from the conclusion of your paper, Rachel. Providers should aim to set realistic expectations regarding pain and activity after surgery, personalize the recovery timelines, and acknowledge possible fears that may be influencing the decision to pursue surgery. So, those were all things we talked about tonight, and I think definitely stuff that I'm going to take away from this paper and try and maybe even identify some of these things in the preoperative process with my patients and set them up for success, I guess, down the road. I don't know if you two had any other additional thoughts before we kind of close it up.
No, thank you, Rachel, for joining us. I'll let you speak if you'd like to, but thank you so much for hopping on. I think these are always fantastic for people to get a behind the scenes. And this is certainly an article that's a little bit different from what we've typically done. And so we're trying to keep things fresh and do something a little bit different. So thank you for your time. We really appreciate you hopping on with us.
Yeah, thanks so much for inviting me, guys. This was really fun to chat with you, and I hope I can come up with a good survey for everyone to use in the future to help with this.
That'd be fantastic. But Rich, before you start talking, I just want to say, go Hawks, Sweet 16, baby.
Let's do it. Let's do it. I'm rooting for them. I'll give you that one.
Thank you.
Um,
That means a
that was
lot.
that was a great episode. So for all of you that's still in attendance right now, this is part of a 12-part series. So that means at the end of the year, you'll get a link to download your certificate commensurate with the number of episodes you attended throughout the year. Thank you all for being here. Great episode. Really awesome discussion. Really appreciate you all. Have a great night.
See you next month.
Thanks, Rachel.
Thank you.
Thanks.
Paw Patrol, Paw Patrol, Paw Patrol.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.